everyone, and welcome to the October 2025 episode of Diabetes Care on Air, a fun way to bring the research in diabetes care to life. I'm Mike Rickles from the University of Pennsylvania.
And I'm Alice Chang from the University of Toronto, and we are your co-hosts for this podcast series.
Welcome to October, everyone. Alice, what fun facts do you have about October for us this month? And will I have to talk like a pirate again?
Well, I would like to say yes, but no, you actually don't have to talk like a pirate again. So that's
I'm,
the
I-
good
I'm sure there's
news.
a lot of relief out there.
No. I'm pretty sure if we were to poll people, they would vote for that. So we haven't done November yet, so you never know, Mike. But remember that September rolls around every year, so you might as well start practicing. So we certainly look forward to it for next September. Now, as for October, it is National Pizza Month in the United States, with the US Congress officially designating it as such in 1987. Now, during National Pizza Month, some pizzerias will give away free slices, so make sure to ask. And October is also National Popcorn Poppin' Month. I'm not entirely sure why popcorn needed a month, but it got October and it became official in 1999 when the US Secretary of Agriculture proclaimed it to be so.
Well, sounds like it's time for movie night. Everyone listening should be ordering in pizza and popping popcorn.
It's the right thing to do.
Well, on that note, bon appetit, everyone, and let's launch into the October episode of Diabetes Care on Air, where we'll be interviewing authors of feature articles from the October issue and run through our popular rapid exchange segment, where we'll each pick 3 articles of particular interest to us. In the October 2025 issue of Diabetes Care is a feature article entitled The Heterogeneity of Type 1 Diabetes, Implications for Pathogenesis, Prevention, and Treatment, an international expert forum published simultaneously in Diabetes and Diabetologia. I'm delighted to welcome the article's first author, Dr. Carmella Evans-Molina. Dr. Evans-Molina is the Eli Lilly Foundation Professor of Pediatric Diabetes at Indiana University, where she directs its Center for Diabetes and Metabolic Disease. Carmella, I'm so glad you could join us.
Thank you, Mike. Thanks for inviting me to talk about this article. It's a really special article because I'm here on behalf of a large group of co-authors talking about this particular manuscript.
And congratulations to you, Carmella, and all of the co-authors for this real tour de force. And my thanks to you as being one of those co-authors for shepherding this effort and all of the contributions through to publication. For starters, can you provide our listeners with some of the background behind this joint American Diabetes Association and European Association for the Study of Diabetes International Expert Forum that was held in 2024 and why this particular topic was selected?
Yes. So as you know, we convened a group of experts day before the 2024 ADA Scientific Sessions meeting. And we selected this topic, I think, for a couple really important reasons. First, in 2022, the US FDA approved the first disease-modifying therapy for type 1 diabetes, and this drug, Tzield or teplizumab, is intended to be used in people who are in stage 2 type 1 diabetes. That means they have 2 or more islet autoantibodies and abnormalities of their blood glucose. And in clinical trials that were performed within the TrialNet Consortium, this drug treatment delayed the onset of clinical diabetes or stage 3 type 1 diabetes by almost 3 years. And so this has been really a turning point in type 1 diabetes, that we have our first therapy that's a disease-modifying therapy for people who are at risk. In parallel, I think many people have been watching with a lot of excitement in developments in the islet replacement field or the stem cell therapy field. And essentially here, scientists in the lab and now companies have developed the ability to transform stem cells into cells that can produce insulin. And so the idea here is that they can be used to replace dysfunctional beta cells or dead beta cells and add back insulin to people who are insulin deficient. So I think both of these advancements, this really remarkable achievement in immunomodulatory therapy, this remarkable achievement in stem cell-based therapies or beta cell replacement, have put us at this really interesting crossroads in type 1 diabetes. And I think the forum was convened really to explore how we can do better, what we know about these two types of approaches to offer to people who have type 1 diabetes or at risk of type 1 diabetes, and what we need to know about the heterogeneity of type 1 diabetes to make even more successful therapies.
Right. And so this concept of heterogeneity, how does this fit in with our clinical concepts of phenotype and endotype? And these are terms that are brought up a lot in discussing heterogeneity and what it might mean for treatment options. And can you tell us the important differences between when we talk about a phenotype and an endotype and how that applies to the heterogeneity in type 1 diabetes?
Yes, I think this is an important concept, and it's actually something that I think we spent a lot of time discussing as a group in the workshop, and then also subsequently as we were putting the manuscript together, because there's, I think, a desire to try to explain heterogeneity, which is really a big issue in type 1 diabetes, and to try to bring terms that can help us understand that heterogeneity. And so there's an interesting term that has been used quite a bit, the endotype term. And so strictly speaking, this endotype term, which we are borrowing from the field of asthma, means that you have a particular type of disease or disease pathophysiology, and that disease pathophysiology could be targeted with a specific therapy. Now, we use that term a lot in type 1 diabetes, but it turns out we probably haven't really identified an endotype yet. It is a very aspirational goal of our field. On the other hand, phenotype, which really just means a set of observable characteristics, is something that we do see a lot and we know a lot about in type 1 diabetes. And just maybe to give some examples. So in type 1 diabetes, if we could, say, identify people who had a strong type 1 interference signature, that's a particular cytokine signaling pathway, it might mean that those people could be targeted for treatment with a JAK inhibitor, which is a drug class that's recently been shown to be effective in preserving C-peptide in stage 3 type 1 diabetes. So that would be an idea of an endotype. We're targeting a therapy to a particular type of disease, pathophysiology. A phenotype, on the other hand, might be something in type 1 diabetes like children have a more aggressive form of type 1 diabetes compared to adults who present with type 1 diabetes. And we know a little bit more from studies like the TEDdy study, which looked at environmental determinants of type 1 diabetes development. And they identified two different groups of individuals who developed either an insulin autoantibody first or a GAD antibody first. And they've been able to use that construct to describe these two groups. Those are likely phenotypes because we don't yet have a drug that could target either of those two groups, but we know that they are quite different in the way that they develop diabetes.
Right. And so you're already alluding to my next question in that children have a more aggressive form generally of type 1 diabetes and rate of disease progression than adults who develop the disease. And what else do we know about the genetic, immunologic, and metabolic factors that influence this disease progression for those that develop more rapid loss of beta cell function versus those that may retain insulin secretion for longer periods?
Yeah, so I think that even though we know a lot, I feel like we just know the tip of the iceberg still. And I think one of my favorite parts of the paper is that as a group, we really challenged ourselves to identify knowledge gaps and to say what should be future research priorities. So I think that we know on a genetic basis that over 50% of the genetic risk of type 1 diabetes is driven by these HLA genes or genes that we associate with regulating immune function. But beyond HLA, we know that there are many other genetic loci or variants that can influence a person's risk of type 1 diabetes. And we're even identifying genetic variants that might be protective. And I think a really important future goal is for us to identify genetic variants that might tell us if a person is going to respond to a particular therapy. And we have done some of that work, and some of the co-authors on the paper have done some of that work looking in trials that have been completed. So doing post hoc analysis of different clinical trials to say that people with a particular genetic architecture responded well to a therapy. And that's been done in a trial called the oral insulin trial. So we know a lot about the menu of genes that might give someone a risk of type 1 diabetes, but we still are really in our infancy in understanding what tissue or in what cell those genes are really giving us the risk of type 1 diabetes. So is it all in the immune system, or is there genetic variation within the beta cells that might make a person have more susceptible beta cells? These are all hypotheses. And we don't really, even though we've been studying type 1 diabetes for a long period of time, know exactly why children and adults are different. They probably have different genetic burden. They may also have differences in their beta cell susceptibility to inflammation or destruction, and they might have completely different immune responses. So we are still gathering a lot of information to try to understand what's different about adults and children. And ultimately, I think we and our group really wanted to bring out how can we understand these differences, and then how could we use those differences to target particular therapies to people and ensure a better success of therapy in type 1 diabetes by understanding this heterogeneity.
Wonderful. And Carmel, what about pancreatic islet development or other pancreatic pathologies that might contribute to type 1 diabetes development?
Yeah, I think we've been really, really lucky as a field because we've had a number of very impactful programs like the Exeter Archival Biorepository, the NPOD program, the Network for Pancreatic Organ Donors with Diabetes program, and the HPAP program, the Human Pancreas Analysis program, that have allowed us to examine tissues from people who have had either autoantibodies or type 1 diabetes and who have passed away and become organ donors. And so by analyzing these tissues, we've learned a lot about the pathology of the pancreas in type 1 diabetes. And if you think about it, we are at a disadvantage in type 1 diabetes research because all the action happens in the pancreas. And it's really hard for us to take a blood sample and understand exactly what's happening in the pancreas. So these tissues have been really field changing, field defining for us to be able to analyze them. And we know that if you are contrasting adults and children, children are more likely to have islets that are infiltrated with immune cells and inflamed. They are also more likely to lose their beta cell mass, and they might have a more rapid loss of beta cells in their disease progression. But even beyond that, some really interesting data suggests that other cells in the pancreas are also impacted. The exocrine pancreas is impacted in type 1 diabetes and may be associated with exocrine enzyme insufficiency. So that may also serve as a biomarker of type 1 diabetes. And we're also learning a little bit more about which beta cells might be more susceptible to immune attack. And some really fascinating data coming from Sarah Richardson, who's one of the co-authors of the paper, suggests that small islets might be a target of the immune system in type 1 diabetes, and that those islets might be destroyed earlier than larger islets.
So timing really seems to be a critical factor in all of this. And you already mentioned one example of a specific treatment strategy, say whether JAK inhibition could target interferon-based mechanisms, and as one example of applying heterogeneity and immune response to prevention or treatment strategies. Other examples you have and analyses of responders and non-responders in clinical trials. Any insights from that work to move forward?
Yeah, that's really the $1 million question, I think, right? Is how could we say when we're sitting across the exam room desk with a patient who's either found to have autoantibodies or newly diagnosed with type 1 diabetes, that this is the right therapy for you. And I think that's our goal. That's always the goal of personalized medicine. It's challenging in type 1 diabetes because our clinical trials tend to be much smaller if you compare them to type 2 diabetes. So we always have to be a little cautious about our observations, but I think we've had some important observations. So we know that if we start a therapy at the beginning of stage 3 type 1 diabetes, or when a person is clinically diagnosed, people who have more residual beta cell function tend to do better. So that, I think, is a really important takeaway message for us, that we need to maybe be acting sooner. And I strongly feel, and we write a bit about this in the paper, is that for a long time, we've done trials at stage 3 onset, but we've never advanced a therapy to an FDA registration. And this seems like a real gap in our ability to impact the lives of people who are affected by type 1 diabetes. So I think that it would be great to offer something to people other than insulin therapy when they're diagnosed. Other observations that we've made about how heterogeneity might impact the response to therapy comes from some of our clinical trials done in stage 1 and stage 2, or before the onset of clinical disease. There's a hypothesis that we are testing now that maybe there is a window of active disease that might make people more amenable to immunomodulatory therapy. But the challenge is, how do we identify that active window of disease? And so that's a really important area of research that people are trying to understand. There are other signatures like T-cell exhaustion signatures that may provide some insight into whether a person would respond to a drug like teplizumab or ATG.
That's really terrific, Carmella. And any next steps or final takeaway messages that you have for our listeners?
So the favorite things about this paper, and I think when you're writing a paper with a large group, it's always challenging. And, I think as a co-author that it took us a while to get the message right on this, but I'm really delighted with the final product. And again, I think one of the really nice things that we did is to take a critical look at the existing data and what we know, but then to identify what we don't know and where we need to place our emphasis. And I think that there are knowledge gaps in each of the areas that we've discussed. There is this, I think, call on behalf of our field to be precise in our language, to really push ourselves when we say the word endotype, whether one exists or what do we need to do to get to an endotype. That is our goal, that we might target a therapy to a particular person in a personalized way. But we're not there yet. So we need to be precise in how we describe things. And we really need to understand heterogeneity, but also we need to understand diversity. And I still think that's such an important goal of our research community, is to understand how race, ethnicity, sex impact pathophysiology and response to therapy. That's a really, really critical part of what we need to be doing as scientists.
Dr. Carmella Evans-Molina, thank you so much for sharing your expertise with us today. I really appreciate all I've learned from both participating in and revisiting your review, as well as our discussion about leveraging type 1 diabetes heterogeneity for future prevention and intervention strategies. I encourage our listeners to access the full article in the October issue of Diabetes Care.
One of the feature articles from the October 2025 issue of Diabetes Care is entitled Glucose Control Sulfonylureas Insulin Treatment in Older Adults with Type 2 Diabetes and Risk of Falls and Fractures, an Observational Study, by Dr. Sharman Shabnam and colleagues, with senior author Professor Samuel Seidu from the Leicester Diabetes Center in the United Kingdom. I'm very happy to be joined now by Professor Seidu. So welcome, Sam, and thank you so much for agreeing to be part of this podcast, and congratulations to you and your colleagues.
Thank you very much, Alice. It's an honor to be joining you here on this podcast. Thank you.
I have to say that I had a lot of fun reading your study. And when I say fun, fun in that the results were unexpected and goes a bit against the grain, which I absolutely love. So the need to individualize glucose targets, particularly in older adults, has been promoted for the past, almost 17 years, since the Accord study showed us that lower glucose targets was not uniformly beneficial. And the general advice has been to aim for higher glucose targets in frail adults and to minimize the use of sulfonylureas and insulin due to the risk of hypoglycemia. So, Sam, with that background, what was the question your group asked, and why was it important to ask it?
So the question was asked from findings from a previous study that we did, also published in Diabetes Care a few years ago. And in there, we noted that elderly patients with hemoglobin A1C below 53 millimoles per mole or 7% treated with sulfonylureas and insulin had significantly higher risk of severe hypoglycemia, but there was no clear link noted in that study between sustained A1C reduction below 7% on therapies such as insulin and sulfonylureas and mortality. There was no clear risk. So the mortality may have been influenced by other factors beyond glycemic control. And so the context of that was intensive glucose treatment. We know it's consistently associated with hypoglycemia. And we also know hypoglycemia is well documented to be linked to severe outcomes, including mortality. So there was clearly a gap. So we had limited understanding on the relationship between hypoglycemia and falls and fractures in the elderly populations with type 2 diabetes. But we know also that falls are a major cause of morbidity and mortality in older populations, especially those with multiple long-term conditions. And fractures have a huge cost burden on health economies across the globe. Type 2 diabetes, as you know, is associated with increased risk of peripheral neuropathy, visual impairment, cognitive decline, and so on and so forth. So the specific role of hypoglycemia, especially in those who are overtreated, in falls, actually remain unclear, despite the fact that we know type 2 diabetes is associated with all those complications. And so we came up with that research question. The objective was to explore the link between sustained A1C reduction below 7% while on these insulin or insulin secretagogues and hospitalization due to falls and fractures. So it was an observational study, as you said, Alice, looking at a large, UK-based cohort, a CPRD. We focused only on elderly populations with type 2 diabetes, and we had to investigate whether intensive glucose-lowering therapies are associated with increased risk of these outcomes.
Okay, interesting. So we know that link between tighter control, more hypoglycemia. We know insulin and SUs can cause hypoglycemia, but yet there was that missing link, and that was kind of what you guys wanted to sort out. So how did you go about conducting the study? You started talking about that briefly, but if you go in a little more detail about how you did the study.
Yes, it's an observational study. It's an observational cohort study on the UK CPRD data link. And we linked the outcomes to hospital episode certificate, which what we call a HES data in the UK, and Office of National Statistics, which records the death records. The time frame was between 2000 and 2017. The cohort follow-up was between that time. The population we included were patients over the age of 70 with type 2 diabetes, and the patients had to have 3 consecutive A1C readings below 7% while on insulin or sulfonylurea therapy. So that was the exposed group. And of course, the non-exposed group was matched individuals with sustained, A1C below 7% on insulin therapy. The matching included the year of birth, year of type 2 diabetes, the gender or sex, number of A1C measurements before the index date, and the time from onset to the index date. So we excluded all patients with severe hypoglycemia at baseline, just because we wanted to focus on the hypo as a link between the falls and the medications. The definition of overtreatment in this cohort was very strict, actually. So we defined it as patients who had sustained A1C levels below 7% while they were on insulin or sulfonylureas. And the first date when overtreatment criteria were met. So those were the exposure definitions. And we obviously measured the falls and hospitalization for falls and fractures, or falls with fractures, or the composite of both. The key word was hospitalization, because that's what we could measure on the ONS or HES database.
Okay, so with that, tell us what you found.
So the analysis was, very flexible. We had to adjust for, everything that we could adjust for: medication history, socio-demographic factors, and clinical parameters. The absolute risk estimation was dealt with by accounting for death as a competing risk factor. And of course, we also looked at, risk estimated at various ages: 70, 75, 80, and 85, detailed in the paper. We found significantly that no clinically meaningful increase in falls or fractures. So that was the top line. And it was a bit of a surprise because we're looking for, an increased risk to make the story, but that was not what we found. There was no statistically significant increase in the risk of hospitalization for falls or fractures in elderly patients with sustained A1C control below 7% while on insulin. The absolute difference between the overtreated and non-treated groups were actually minimal. So we're talking 0.2 to 0.6% at 5 years and 0.5 to 0.8 at 10 years. And significantly, we found that age was a dominant risk factor. Age itself was much stronger a predictor of falls and fractures than the glycemic overtreatment. Okay, so no matter what the A1C level was, the more advanced your age, the more likely you're going to get a hospitalization for falls. And we thought that this suggests the falls prevention strategy focus more on age-related vulnerabilities, such as frailty, balance, multiple long-term conditions, than solely on just the glycemic targets.
Okay, so let me get this straight. I'm going to say that your group has been disruptive then in terms of our general thinking, right? Because your previous study that you mentioned demonstrated no association with mortality.
That's correct, yeah.
And then this study has now shown no association between sustained A1C under 7% while on insulin or sulfonylurea with hospitalizations for falls and fractures in those age 70 plus. So as you said, unexpected, sort of goes a bit against the grain. Now, people with severe hypoglycemia were excluded. So why do you think there was no association that was found?
So yes, obviously it's an observational study. It cannot make hard pronouncements on these findings. But we do have a few ideas on why this might be the case. Although insulin and sulfonylureas are known to increase the risk of hypoglycemia, which can lead to dizziness, confusion, and falls, as we all know, our study found no clinically meaningful increase in hospitalization for these outcomes. And one of the things to consider is the exposed group in our study had only a slightly lower A1C level than the non-exposed group, 6.4% versus 6.8%. That's very modest. This modest difference suggests that both groups were relatively well controlled, potentially reducing the contrast that you could see in the hypoglycemic risk. I don't know if I'm making sense, because you are comparing the exposed versus non-exposed. And if both groups are so well controlled, the contrast of hypoglycemia risk is kind of minimized. I think that's one of the reasons. The other reason, I think, is that both the exposed group and the non-exposed groups had a high burden of comorbidities. For example, heart failure, stroke, and dementia. All of these themselves are strong predictors of falls. And this may also have diluted the specific impact of insulin and sulfonylurea-related hypoglycemia on the falls. There is also the issue of residual confounding, because this is an observational study. Important factors such as the functional status of the patient, frailty, the use of multiple risk-increasing drugs were not captured in our data set. And these unmeasured variables could have influenced the results. And also the issue of the outcomes we measured. The study only assessed hospitalized falls, potentially minimizing the less severe falls that did not require admission. Hypoglycemia-related falls may often be minor and managed outside of the hospital setting, but we had no way of capturing all of these minor falls. And then we also, as you said, excluded patients with prior hypoglycemia. As you know, hypoglycemia begets hypoglycemia. Okay, individuals with a history of hypoglycemia were excluded. Possibly, this removed those most vulnerable to hypoglycemia-induced falls from our analysis. And then finally, I just thinking, out loud, I think age itself was a very strong determinant of falls, and the incremental risk from overtreatment may have been overshadowed by age-related decline in balance, muscle strength, and bone density. So those are some of the reasons. I don't think, even though the findings are discordant with what we know, I don't think you can read too much into it. There are a lot of reasons why this could have gone the other way. The suggestion for the data was that there was a trend towards harm. It just didn't reach statistical significance. So yeah, I would probably say we should be more cautious. Age is a strong predictor of the falls, not the A1C per se. The medications, the side effect of the medications may be associated with hypoglycemia, which may be predicting falls, but the medications per se, or the low A1C per se, was not what we found here. It's just, a question of caution.
Which brings the question of, okay, for our audience, what are the clinical implications? Because we've used the term overtreatment in this conversation. So is it overtreatment? And is it still appropriate for us to preferentially use non-hypoglycemia inducing antihyperglycemics, particularly in the older age group? Because that's the general teaching, right? Generally try to avoid sulfonylureas and insulin as much as you can in that older age group. So what do you think the clinical implications of these data are?
I think you're right. Our findings provide cautiously some reassurance that intensive glucose therapy, when carefully monitored, you mentioned non-hypoglycemia inducing agents, that may, if you do that, that may not necessarily significantly increase the risk of falls in elderly patients. However, vigilance for hypoglycemia remains essential, especially in those, with additional hypo risks. So yeah, I think the individualization of treatment is still important. That would be my main message. I wouldn't, as far as go to say that in elderly patients, sulfonylureas and insulin do not cause falls, so go ahead and prescribe that. No. What I will say is, the lower A1C per se on its own will not be associated with the falls. And so if you identify your patients correctly, and this is why the functional status and the frailty status is extremely important when assessing the risk of falls, because age is just a number. You can have a 70 plus, fully fit, independent patient and a well-controlled A1C below 7% with agents that do not cause hypoglycemia may not necessarily be harmful to that patient. So that individualization is what we also recommend.
Okay, excellent. That's good advice, right? I mean, look at the person sitting in front of you and determine their fall risk almost independent of the glucose and their treatments. With that in mind, then make decisions around glucose targets and treatment choices. But it's not a hard no against sulfonylureas and insulin, but it's also not a yes, everybody use it. It's safe and completely no issues, right? So I think that makes sense. There's still a role for us to think when we're seeing patients and make individual decisions. So finally, Sam, what are future research directions for this particular topic?
I think future studies should include community level data, not just hospital outcome data, or indeed self-reported falls to capture the full spectrum of fall-related morbidity. The issue of functional status and frailty indices has been mentioned a few times, and activities of daily living were not available on CPRE data. So I think future prospective studies or data sets that include frailty assessments could clarify which subgroups are more vulnerable to overtreatment related harm. Additionally, although overtreatment was used as a proxy, incident hypoglycemia events during follow-up were not systematically captured. And that is usually very difficult. In the UK, it's not very well coded in primary care databases, so we don't capture that very well. So in this day and age of continuous glucose monitoring, I think there is an opportunity for us to use CGM to detail clinical outcomes such as hypoglycemia and see how that directly affects falls. And we have got a study already ongoing looking at the use of continuous glucose monitoring in de-intensification in the elderly frail populations in care and residential homes. The other thing worth considering is how we disentangle individual contributions of sulfonylurea versus insulin to fall and fall risk. That hasn't been done. We know insulin causes hypoglycemia. There is also the use of sulfonylureas. A lot of patients in that population will not normally be on sulfonylureas over the past 17 years. But we're still not able to get rid of insulin completely because there are some patients who you really haven't got any options in that population other than give them insulin. So we need to be able to disentangle the individual contributions of both drugs. And then finally, I think intervention studies could assess whether de-intensifying therapy in tightly controlled elderly patients can reduce falls without compromising glycemic control or quality of life. And like I said, we've got an EDMED study, which is a feasibility study we are doing, hoping to do a proper intervention study following on from that.
Sounds like you've got a lot of work ahead of you, Sam, which is great. So I want to take this opportunity to thank you. Thank you, Professor Sam Seidu, for sharing your expertise with us, and congratulations again to your colleagues for this thought-provoking analysis. And I really enjoyed not only the results, but also the discussion around why we saw the results that we saw, and then how we could potentially apply this clinically. So thank you again for joining this podcast, and I encourage our listeners to read the full article in the October issue of Diabetes Care.
Let's move on now to the Rapid Exchange segment, where Alice and I will discuss articles we each found of particular interest this month. Alice, why don't you start us off?
Sure, Mike. So my first pick for this month is an analysis from the long-running Dacheng diabetes study in China by Dr. Yan Chen and colleagues from Beijing, China. In 1986, over 110,000 residents of Dacheng, China, underwent glucose testing to identify people with impaired glucose tolerance to participate in the Dacheng diabetes prevention study. When conducting those glucose tests, 630 people were identified to have newly diagnosed type 2 diabetes. 576 people had impaired glucose tolerance, and 519 age and sex-matched people with normal glucose tolerance were selected as controls. Remember that among the IGT group, some received 6 years of lifestyle intervention through the Dacheng diabetes prevention study, and some did not. This analysis examined the incidence of stroke across the 3 glucose level groups over a 34-year follow-up period. So what did they find? Over 34 years, the cumulative stroke incidence in the newly diagnosed type 2 diabetes, impaired glucose tolerance with no lifestyle intervention, and impaired glucose tolerance with intervention groups were 65.4%, 62.8%, and 49.8%, respectively. When compared to the normal glucose group, and after adjusting for risk factors, the risk of stroke was significantly higher in the newly diagnosed diabetes group. Hazard ratio was 1.8. The IGT non-intervention group, hazard ratio 1.52, and the IGT intervention group, hazard ratio 1.33. Compared to the newly diagnosed group, the IGT group that received lifestyle intervention had lower risk of stroke. So for me, this analysis highlights a couple of things. Higher levels of dysglycemia is in fact associated with higher stroke risk, but also that there was a lot of stroke over 34 years of follow-up. So clearly, there was still much work to do.
A lot of work still to do for sure, Alice, but also highlights the important stroke risk reduction that comes with early identification and lifestyle intervention for those with prediabetes. And this is important because, as we learned in our June interview with Dr. Justin Achufo-Chigui, just how limited resources are for implementing lifestyle intervention programs, at least in the United States. So, turning now to the United States, my first pick examines the real-world frequency and characteristics associated with remission of type 2 diabetes. Mr. Barun Tapa from Kaiser Permanente Bernard J. Tyson School of Medicine in Pasadena, California, working with senior author Dr. Luis Rodriguez from the University of California, San Francisco and colleagues, examined the electronic health records of over 500,000 adults with type 2 diabetes treated with glucose-lowering medication and excluding those who underwent bariatric surgery. And they looked for remission as defined by a hemoglobin A1C less than 6.5% at least 3 months following cessation of glucose-lowering medication. And over the 3 years of follow-up, about 3% or 16,000 individuals achieved diabetes remission. However, about 1/3 of those subsequently went on to relapse. So while this is uncommon, diabetes remission was more likely in those with shorter diabetes duration, lower baseline hemoglobin A1C, and those requiring fewer glucose lowering agents at baseline. And so, again, highlights the significance of targeting intervention earlier in the disease course.
And those factors that you just listed are established in other studies as well as being predictors of who can successfully achieve remission. But I think this is a reminder to all of us that we need to have that remission conversation instead of making that assumption that people are not going to be able to make the changes required, because every now and then we're going to find that person who is willing to do what's needed to be done and may in fact achieve success. So I think this is a nice reminder of that. But the relapse rate is high, typical of what we've seen elsewhere. So again, setting expectations, even when people do achieve remission, is another important message I would take. So thanks for that, Mike. My second pick actually piggybacks somewhat on the feature article interview you conducted last month, Mike, on the STRIDE study and the effect of semaglutide on functional outcomes among people living with type 2 diabetes and peripheral arterial disease. Now, although STRIDE was not powered to look at major adverse limb events, the limited number of events seemed to favor a possible beneficial effect with semaglutide. In this month's Diabetes Care issue, Dr. Alexander Hong and colleagues from the University of Southern California in Los Angeles, United States, performed a retrospective cohort study utilizing a federated electronic health record network to compare the risk of lower extremity amputations between new users of GLP-1 receptor agonists versus SGLT2 inhibitors. After propensity score matching, they identified matched cohorts of over 180,000 GLP-1 receptor agonists and 180,000 SGLT2 inhibitor recipients. At 3 years, the GLP-1 RA cohort was associated with lower risk of major lower extremity amputation, minor lower extremity amputation, diabetic foot ulcers, and mortality. Of note, though, although the GLP-1 RA cohort was associated with greater major amputation-free survival, the difference was statistically significant but very small. 99.69% of the GLP-1 RA cohort was major amputation-free, compared to 99.64% of the SGLT2 inhibitor cohort. So what would I take away from this is that it's possible that GLP-1 RA use is associated with less lower extremity amputations than SGLT2 inhibitors, but the incidence is so low, which is good, which is very reassuring. And the difference may be due to GLP-1 RA having a protective effect in light of the STRIDE study, as opposed to SGLT2 inhibitors having a negative effect.
These are reassuring findings, Alice, and demonstrate the power of analyzing large samples of real world data that help to translate findings from clinical trials to expectations of these interventions in clinical practice. Putting it all together for me, I will lean towards starting GLP-1 receptor agonists for those with peripheral artery disease and risk for lower extremity amputations, but not avoid SGLT2 inhibitors in the same individuals if there are other indications such as albuminuric diabetic kidney disease or a history of heart failure. But when starting SGLT2 inhibitors, now in addition to counseling about the increased risk for urinary tract infections and in women, vulvovaginal candidiasis, there's evidence of increased risk for phimosis in uncircumcised men. In my next pick, Dr. Christine Lundberg from Aarhus University Hospital in Denmark and colleagues examined 32,000 male initiators of SGLT2 inhibitor therapy and compared them to approximately 15,000 male initiators of GLP-1 receptor agonist therapy using an emulating target trial approach. SGLT2 inhibitor use was associated with a nearly twofold increased risk of phimosis, which in adults is caused by infection and inflammation of the foreskin. And this during the first year of treatment that remained elevated in terms of risk over the 8 years of follow-up relative to GLP-1 receptor agonist use. Nevertheless, the absolute risk of phimosis among SGLT2 inhibitor users was low, just 1% after a year and 5% after 8 years of use in a country with estimated prevalence of circumcision being below 20%. So, also important information to consider when involved in counseling discussions.
Yeah, absolutely. I think it's only after SGLT2 inhibitors became available did I ever start asking my patients if they've been circumcised or not, because that never used to come up in the consultation, but now is a regular question. And I would hope that the phimosis is in fact preventable as long as we have conversations around genital hygiene when using SGLT2 inhibitors. So this is a good study and reassuring in that the numbers are very low, but obviously the risk is there, so we need to be aware of it and counsel accordingly. Now, my final pick is hopefully a reassuring one. Mrs. Janni Larsen and colleagues from university centers in Denmark evaluated the risk of treatment for sight-threatening diabetes retinopathy during and after pregnancy in women with type 1 diabetes compared to non-pregnant controls. This is a very relevant question to answer because we've always been taught that pregnancy is a time when eye disease can get worse, either due to the act of tightening glucose control as well as possible effects of pregnancy itself. In this Danish cohort study of over 1,000 women with type 1 diabetes giving birth in 2013 to 2022 with known diabetic retinopathy, matched with over 1,000 non-pregnant women with type 1 diabetes with similar baseline diabetic retinopathy levels, they found that the risk of treatment for sight-threatening diabetic retinopathy was similar in both groups. Progression to proliferative diabetic retinopathy was also not higher in the pregnant group. I think this is good news for women with type 1 diabetes who are considering pregnancy. Of course, we still need to ensure that eye examinations are performed before and during pregnancy, but perhaps current comprehensive preventative treatments are truly making a difference.
That is great news, Alice, and these findings should be celebrated as emblematic of the progress in treatment for type 1 diabetes, leading to meaningful reductions in pregnancy-related complications for women. My last pick examines the effects of physical activity on glycemic control in youth with newly diagnosed type 1 diabetes. Dr. Desi Zahariva from Stanford University in California and colleagues for the Teamwork, Targets, Technology, and Tight Range, or 4T exercise program, evaluated physical activity patterns and associated glucose metrics across the first year following type 1 diabetes diagnosis among 98 adolescent youth. Compared with sedentary days, days with at least 10 minutes of vigorous intensity physical activity were associated with a decrease in time above range of 3 percentage points and an increase in time below range of less than 1 percentage point, such that the time in range increased by over 2 percentage points during the 24 hours following exercise. Completion of each one of up to 4 quarterly structured exercise education sessions was further associated with even greater gains in time and range, with reductions in both time above and below range. So these results add to the developing literature surrounding the safe use of physical activity to improve glycemic control in type 1 diabetes.
And really supports what we should be really advising everyone, including ourselves, I guess. You and me, Mike, we've had multiple conversations about exercise and sleep and the fact that we could both probably do better. But certainly in the people that we serve living with type 1 diabetes, we should be also encouraging exercise. But you're right, it's about doing it safely. And these data certainly help to support that. Well, this brings us to the end of the October 2025 episode of Diabetes Care on Air. Thank you to Professor Sam Seidu and Dr. Carmella Evans-Molina for sharing their expertise with us.
And a big thank you to you, our listeners, for listening. Please remember that Diabetes Care is continuing to take submissions of original art for consideration to be included on a future journal cover. Don't forget to subscribe to get notifications about new episodes of this podcast. Thank you for tuning in.